This is Dr. White again, and I'm going to do the second phase of caved-in bicuspids. And I maybe should tell you I'm a general dentist. It's done nothing but orthodontics and some TMJ work since 1970. Then I teach for the AOS, or the American Orthodontic Society, which is a organization that's dedicated to teaching general dentists and pedodontists orthodontics and trying to get the best thing we can possibly get out of them to do the best work we possibly can. And that's, if you're interested in orthodontics, you can join the American Orthodontic Society. We have a lot of good instructors that are teaching good solid orthodontics. Anyway, this subject of caved-in bicuspids, I've dealt with it quite a bit, as I said in the first phase. This young man here, as I said, every one of these cases, we had 4 cases to show, and we were doing the second 2. They have other things wrong with them. You hardly ever get a case with just one thing. Now, this young man has a tremendously deep bite here. I mean, you don't even see his lower anterior teeth. And so we're going to open the bite. We'll push these up here, up, the upper and the lower down. And we'll do that with intruding wires. And if you've got a high angle case at all, we like to put pads between the molars back here to put a lot of extra muscle pressure on those teeth, because you're going to tend to intrude these, and it'll tend to extrude these. And we intrude the lower here, and it will tend to extrude. As we push these down, it will tend to push these up. So we put something here where they bite on it hard, and you can open the bite and not change the geogen angle at all, on a high angle case. This is not a terrible high angle case, but we did bond these blocks on him. And as I said before, I'm going to draw all over these so you can kind of keep up with what I'm talking about in here. So we're going to open this up, and we're going to expand both sides of the mouth right here. And we're going to pick this up and take this down. And we're not going to increase the vertical dimension of the face hardly any, since we'll be chewing on some pads back in here. So if you go through a bunch of these videos that I'm trying to produce, you'll catch on to a lot of the tricks of the trade here doing this. Alright, he's class 2, of course, kind of a class 2 division 2. So as we open the bite up, and we free these teeth and torque them and raise them up, bring these down and kind of torque them forward, the jaw can move forward almost without any class 2 elastics at all. You can just free the mandible up on many of these class 2 division 2s, and the lower jaw will move forward. That gives them a better jaw relation back there, and they have less TMJ problems. So I'm going to show you later on, this point will be back in here. This one here, this one back here, and this point will be back in here, and this will be class 2 be corrected. And if you keep the bite open, this will stay corrected indefinitely. Now this side of the mouth is class 1. So I'm going to go back to the other side. As we correct this, we have to correct the form of the arch form. Will get kind of warped in here as you pull one side back and not the other side, but you go back and then you coordinate your arches. These are some little tricks of orthodontics you need to know anyway. So your midline will be off. One side's class 2, so the midline will be off too in here. Okay. Now you can see how this is caved in here, and these teeth are crowded up, and so we're going to intrude these. They'll be pushed up into the bone structure up there. The bone will move with them. You don't bury the teeth. As you move the teeth up, the bone structure moves with the teeth. Now you can take one tooth and shove it in bone if you leave the other two up. But if you take a group of them and elevate them, the whole bony alveolar bone structure moves with the teeth. And here you can see where this is caved in like this. This is 1979 when we did this, but the principles are just as valid today as they were then. There's absolutely no difference in the principle of what happens in here. Alright, we use these intruding wires. It's something I developed about 35, 40 years ago to pull this wire down and hook it on here. Even though we're in a wildcat wire here lining the teeth up, we can start opening the bite day one. When you put the first things in their mouth, you can start opening their bite. If you'll learn to use a double arch wire situation, you got to have a different tube set up. You got double tubes on the bottom and triple on the top. You put your intruding wire in there. Now this wire will go way down here. See, as we pick it up, so it's pushing this down, it's taking. You bring the wire up here, and then the wire is going to bring the teeth down in this direction. As it pushes them down, there has to be an equal and opposite force, and so the lower molars will tend to go up. Alright, if you don't want the bite to open up, then you've got to put something in here that makes them chew harder. Now, the upper comes down here, we pull it down, it pushes these teeth down and tilts them back, or tries to, and it's going to pick up the anterior teeth. So the force to intrude the anterior teeth, it's going to bring the bone structure and teeth and everything up. These will try to go down. Just as much force going down as there is going up. So a lot of people get into orthodontics, they don't fully understand the mechanics of what's happening in there. So you need to know that. And so I hope if you don't, you can run over these darn videos till you're blue in the face, and it'll keep telling you the same darn thing. Now, so we put acrylic pads in here on the teeth, and that causes you to chew more back here and press these teeth together harder, and the teeth will not come down, but these will go up. And the vertical, the height of the lower third of the face, the vertical height, will hardly change at all if you do it that way. But if you don't, and it's a high angle case, and you don't put anything in here, you'll push these teeth together, and whatever they go together, it's going to increase the height of the lower third of the face. And if you add a couple of millimeters back here, it might be 5 out here in front. And that makes people look ridiculous. You need to keep the vertical height of the face down if you're going to do that. So anyway, I hope you learn these things as you go in here and do orthodontics, that you can do a darn good job of it. That's the goal of this orthodontic organization we're at here, the American Orthodontic Society. We have a board setups you go through. You can learn orthodontics now. You don't have to guess at it. You don't have to crawl around on your belly sneaking into places to learn it, which we did years and years ago. But you can learn it now, and I hope you do. So here's the intruding arches. And if you want to learn how to intrude a case, you got to put triple tubes on the bottom, on the top, and double on the bottom, and you can put these intruding wires at the same time you put the flexible wire, and day one you can put all this mess in their mouth, and you'll have this thing going before somebody else can get the teeth lined up enough to put a stiff enough wire to even start opening the bite. So, and you can put these, they've got these little fancy wires now that are shaped like such, but they just don't work. They intrude these teeth at the same time they intrude this. This is much, much better if you learn how to do it. I have a hard time getting people to commit themselves to learn how to bend the wire and to do some of these things. And I hope this will aid you in doing that. Now, this is just acrylic. We take triad acrylic and bond it onto the bottom arch. Put a little Vaseline up here so it's just on one arch. But if you don't think that'll intrude your teeth, you just bond some on yourself. And it bonds you about a 3 or 4 millimeter pad on the both sides, and you'll hammer the dickens out of it. In other words, your muscles will overwork, and these teeth will not erupt toward one another as you open the bite. If you don't believe that, just try it on yourself. It'll work. So while the little flexible wire here is unraveling and everything else, we're opening the bite from day one with this. And that's the fastest way. I know it'll knock several months off your treatment time if you'll learn how to do that. Now here's just some pictures of it in the mouth, but there's the intruding wire. And I started putting these intruding wires in about 40 something years ago. And then other people have started, and some of them have caught on to it. But I've got the case I'll show in that intruding wire. I'll show you the case that we started back in 1971 or 72, something like that, somewhere back there. Okay, here we go with the case. Now we're opening the bite, and so we're going to open it up and the case will move forward. And as we're opening it and leveling it out, then we're going to come in and just expand the arches. And as we open it, free the mandible, it'll move out into a class 1 relationship. So here we are. We've already finished the upper part. We've torqued it. As you open it and these teeth were tucked in, they will tend to torque out correctly. If you don't torque them correctly, then put your rectangular wire, have your torque on it, and you hold them and put them in the correct torque relation there. Okay, this is the uppers finished. Now we put a retainer in there and we have a bite plate. Put a bite plate on every one. This retainer was made years ago. Now we just take this around, go up and come back and solder back in here. It still does the same job though. I mean, it will tape it, but they tend to break here, so that's not the best way. But don't go across the occlusion with any kind of wire. You do not need any kind of clasp in there. You put this in if you want to hold it in there and really, you put a little tiny wedge of acrylic or composite underneath your arch wire and you snap it over there, you can't hardly take them out, see? So you do not need to cross the occlusion. And all these stupid retainers, they put in with a thing coming out like that. They bite on that. When they're wearing it, they're biting and their teeth are going one way, and when they take it out, they go the other way. This way the teeth will erupt together and come to fit together, and when the retainer's in, they won't be moving one way, and when you take it out, they move the other way. So this is what I hope that you will learn how to do. Okay, here it is after we finish the guy. Now, this came forward almost without any effort, just by, excuse me. Maybe we can edit that cough out of there. But it came forward into a class 1 relationship, and we've opened the bite, you see. This came up, this went up, and this went down, and then the mandible was free to come out here like that. And that happens just during this is kind of a class 2 division 2 case, or it is one, and you don't want to take any teeth out on it, but you need to learn how to do them. Now on this side it was class 1, and it's still class 1, see? So we would have to hold it in place and move the other, because as you bring one side back and leave the other side, it will distort the curvature of the arch. So you have to re-establish the curvature of the arches so that they coordinate together. Now here it is finished. The midline's not on. I'm not worried about that. The cuspid relation is tighter over here, and it shipped it to one side. It's not perfect, but it's darn not better than it was to start with. And now we've moved these teeth out like this, and now you see those teeth, and if he'll stay with his retention, this will stay there the rest of his life if he just stays with it. And you can see how we've expanded the arch here, bringing it out in this area and this area, lining up the teeth and all this. Now this tooth that's dead looks to me like it's dead. It was that dead when we started it. This treatment didn't kill the blooming tooth. Now the lower at this point is relapsed a little. I should have had something bonded on there, but I didn't. We definitely bond them all now on there to hold it in place. And here's the facial structure. And we didn't increase the vertical height of the face at all in doing this case, but we opened the bite away a lot. And if you had not had anything bonded down in here, these teeth would have erupted together. And whatever they erupt about, if you add 2 millimeters back here, you might add 4 out here, and you'd bring this chin down further and give this guy more vertical height to the face. So learn how to go in there and bond these little pads on there. You can turn out with a lot better looking orthodontic cases than that. Now here's number 4. This guy had a terrific TMJ problem. This is 1982 when we started, and I followed this fella for years. And we had to get him out of pain. And so he had a locked mandible back there, and his joint was giving him all kind of trouble on both sides, and he has taken so much medication he couldn't hardly do his job. Now he's got a deep bite, he's got crowding, he's got a whole stack of things, and a terrible TMJ problem, which you don't see too many men as bad. And we get about 20% of our TMJ stuff is men and about 80% are women. That's kind of the way it comes out. But now we're going to open the bite and do all these things. We're going to expand this arch. We're going to use a Big Daddy arch wire, which we cover in some other of these videos more in detail. Now the class 1 relation on the left side is pretty good. The right side is way off, you know, in here. So anyway, now here the the left side of the mouth is class 1 to start with in here. Now he's biting down and locking his lower jaw back, and he's worn the backs off the upper front teeth right here. They come up and sit right on those teeth right there, and he's got a cross bite in there, and he's got a TMJ problem that just won't stop, you know. Now we got a bicuspid that's out of place. We got to bring it, we got to go down and bring it over. He's chewing on the side of it. These teeth are crowded, and you look at it and think, well, you can't put all these teeth. You can put every one of these teeth in, the guy will look fine. You don't have to worry about it. We're going to expand this out. We're going to intrude these teeth right here, and I want to spread this space out and move this tooth into that spot right there. And you can do that just as well as I can if you just learn how to do some of these things. Now, you look at the model from the tongue side, and the third lower anterior teeth are almost biting into the roof of the mouth up here. Well, he can't move his jaw forward. It may want to come forward. It's biting the back side off of the upper centrals and everything. And this bicuspid is completely out of occlusion, wearing on the side of it right here. So we're going to kind of intrude or level it out and bring it over and level the whole moving thing out, you see, going in there to do it. Now, here we're way into treatment. The mechanics of it, we're using twin brackets up above. I don't Now I like these brackets here with the wings. They're much better. Got wings on all these down here. And we're expanding this. We've opened the bite now quite a bit, you see. The bite, these teeth are way down here, so we probably use the intruding arches to do that. I'm not showing you the whole ball game here, but we're interested in expanding the bicuspids in here in that vacuum that sucks them in like that. So anyway, we go through the case. Now we've expanded it and we made room and we're bringing the teeth into alignment now. That one lateral up there is apparently dead or something wrong. It was that way to start with though. Now we kept trying to pull this tooth through it. It kept sticking out us and I got kind of anxious about bringing it over, so I put a big daddy arch wire on there. Man, I put all the force on this right side on that bicuspid to pull it through and tied it down over here on this side, and man, it popped that thing through. And I've got several videos on the big daddy arch wire that we've been using for years, and you can expand anything walking or breathing. It gets into your office. I don't care what kind it is. As long as they're alive, you can expand the arches with those things. So, but just be careful. Don't stick them on some idiot that won't come back in, because their teeth will be sticking out their cheeks if you activate it very much. Just activate them a small amount to start with. Anyway, they're excellent for expansion. Now when you expand an arch, if the teeth are leaning in, it'll straighten them up. If they're leaning out and you go to expand them, you got to put a lot of buccal root torque to bring this part out too, see? And you have to get into a rectangular wire before you do all that, and put a lot of buccal root torque to bring the roots out down here when you do that. So there's more to expansion of the arches than a lot of people think. They think just expansion. Well, you've got to know how to put buccal root torque in if you're going to do this expansion properly. Okay, so here we've expanded this out, jumped that over, and now we freed this mandible up and got it out here in the open where it can advance and open the bite, and this TMJ problem goes away. That happens so many times that you allow the mandible just to move forward a millimeter or millimeter and a half sometimes. They'll free it up and they'll stop having pain. They've been hurting for years, you know. It is unreal what putting the jaw where it wants to go. If you left the jaw and let it choose where it wanted to close, it wouldn't have too much TMJ problem. You'd have arthritis and extreme stress and stuff like that. Okay, but very few people's joints would hurt if they could close where they want to. But what happens, they go together, and when their teeth start to meet, they pull their jaw backwards, and it puts crowds the retrodiscal area back there, and they start having problems. Now, some people are just tougher than dickens, and you can't hardly hurt their jaw joints, but other people, you just look at them cross-eyed, and their jaws will hurt. So this is something you have to learn how to deal with. And if you think you can do orthodontics and it doesn't have any darn effect on the TMJ, that's about as dumb a thing as you can think of. You know, it has something to do with it. So does your regular dentistry. You can put a crown with a thick lingual part on it, push the mandible back, and come down with TMJ problem. And people, dentists in general, do not understand enough about temporomandibular joint stuff. And that's something everybody ought to know. And you ought to examine everybody you work on before you start and find out what kind of click and what kind of pain or discomfort, and learn how to deal with TMJ stuff. And all this malarkey about orthodontics having nothing to do with it, or even general dentistry or crown and bridge or whatever you have, that all has something to do with the TMJ. So we don't want to ever crowd the mandible back in whatever you do for anybody. Okay, so we push this down, this bicuspid. This was back in 1983. We rounded it out. So the whole upper arch has been expanded. The whole lower arch has been expanded. And we freed it up. We opened the bite, and the mandible came forward into a better relationship. And the guy doesn't have any TMJ problem, and I have him wearing retainers. I told him the rest of his life, if he lets his bite deepen again, it'll push the mandible back. And I've kept up with this guy up into 2000s and maybe 8 or 10 or somewhere around there the last time I saw him. But he's not having any TMJ problem anymore. And the teeth are fitting together like that, and he wears his retainer. You can see he really wears it maybe too much. Or you should take him out and brush your gums a little more often. Excuse me, and take care of that gum tissue underneath them. But I do want people to wear them and wear the bite plate, and the bites won't deepen. And so this is that bicuspid that jumped through, and it's kind of slipped a little bit there. And I think, well, let me show. I'm going to show the guy. That's 1980. That's 86, and we've got some real older pictures on him. And now he's getting a little older, and you'll see as we keep watching, he keeps coming back. That's 91, and he's turning a little gray, and it's interesting to follow. 93, he's gotten grayer. Now he'd been wearing a toupee. He came in one day during there bald, and I didn't realize he had this toupee on, but he wears it. He's got a nice smile, no TMJ problem, and he gets along great, you know. And that's a satisfying thing to be able to do. Here's a guy that was taking so much medication he could hardly hold down his job just to keep the pain down. Those are just band-aids on a sore that won't heal, you know. They had to open the bite like that and free it up and let the mandible come forward. That was class 1. Now this side went in just real good. Here we jumped that over. Now somewhere down the line he lost a tooth in here, I think. I don't think he had it restored. This is 93, 82, 93. Here's some panorexes on him. That was going back to 82, 83, 91, 93, and that's 82 again. Here's 2004 now. Here's the guy's mouth, 2004. And it's holding up. It's relapsed slightly and stuff like that. And here's the way he looks. Now that's 2004. He's gotten gray beard, but his teeth are still fitting together good. He doesn't have any jaw joint problems. Now he's lost a tooth in there, and he didn't have anything put back. I could kick him for that. He should have had something restored in there. And he's got some relapse from not restoring that tooth. But he's still wearing his upper retainer. And I don't know, I think I have something even later on him. Okay, that's 1984. That was a retainer he wore. We made in 1984. And he still had it in his mouth when I made this one in 2007. So the retainer had held up a long time. That's 2007. And this is 2007. He's bald-headed and gray now. So old age is working on him just like it is on me and you and everybody else. So that finishes the caved-in bicuspids, and it adds a little extra on different things about the different cases. And I'm going to stop this now and we'll finish it out. Thank you for listening to it. It took about 29 minutes.